Hi guys, so we are going to go over the concept of fluid and electrolytes. So this is your recorded lecture for this content. Here are the learning outcomes. I'm not going to read them for you guys, but there they are. So I know this is somewhat is going to be a little bit of a refresher from when you had Nursing 111. So I'm going to kind of go over this concept of like the fluid aspect of it, because it should be, like I said, a refresher from A&P, as well as 111 with that you've had here. So the concept of fluid and electrolytes. So some fluids that are within the body are blood, serum, albumin, urine, bile, hormones, cerebrospinal fluid. Some factors that affect the total body fluid include age, gender, and body fat. Um, some parts of the fluids within the body, you have the intracellular, which composes about 40% of total body weight. Where fluid found inside of the cell, it's composed of water, dissolved electrolytes, and proteins. And then you also have extracellular fluid, which is body fluid not contained in cells. There's three components. It's the interstitial compartment, intravascular compartment, and the transcellular compartment. This contains about 1/3 of the body's water compartment. So with the electrolytes, the distribution and composition of body fluids, electrolytes, as we know, are charged ions. They're capable of conducting electricity that are dissolved. They are also dissolved within the body fluids. They're responsible for various chemical reactions which produce energy within the body. The energy generation occurs as the cations, the ions again with the net positive charge, and the anions, the ions with a net negative charge, combine and then split. Because of this massive energy charge, it results in an energy creation for your organs to appropriately function. So this is also where like cardiac and skeletal muscle contractions occur. So especially with cardiac muscle contractions, potassium is very important, as well as sodium, for the muscle contractions to occur. So if you're like potassium is completely off balance within your body, you can have cardiac arrest. So it's very important to have these in balance, which brings me to homeostasis. Homeostasis is where the multiple physiological processes are in balance. So that means the fluids that are within your body and the electrolytes are all copacetic, they're all in balance. Um, so when you have somebody with an imbalance, it can result and have massive effects on the patient. An imbalance can, create or can affect somebody who has a chronic illness, and it can create an acute illness. Um, and vice versa, chronic and acute illnesses can create an imbalance. So it kind of depends on what kind of illness is happening, if it's something that's chronic or acute in a patient, and how it can affect it. So here's a little bit of things about some of the electrolytes are positive versus the negative ions. So normal fluids and electrolytes, again, like I said, factors that affect the total body fluid are age, gender, body fat. Fluids comprise about 60% of a healthy adult's weight is in water. It's necessary for normal cellular function. It transports nutrients and electrolytes to the cells. It dissolves and carries waste products away from the cell. It acts as a medium for food digestion. It lubricates joints, membranes. It's an insulator for your body. It's a shock absorber. It regulates body temperature. So those are all of the big things that fluids do. So again, we were talking about intracellular fluids. So it's about 60 to 65% of your body is compromised of this. It's the fluid found within a cell, and it's about 2/3 of your content. And then extracellular, it's all fluid being found outside of the cell, and this is about 30 to 35% water. Um, It's the intracellular fluid. Again, it's found within cells, makes up 2/3 of the total fluid, and it's vital to cell function. Again, extracellular, extra outside, it's outside of the cells. And so extracellular is composed of the intercellular or interstitials, most how you have probably heard the word or term, plasma, and the transcellular. So those are the three compartments within the extracellular fluid. So how is this distributed? So again, intracellular found within the cells of the body, 2/3 of the total body fluid found within adults. It is vital to normal cell functioning. It contains solutes such as oxygen, electrolytes such as potassium, magnesium, and phosphorus, and it also contains glucose. So all of these are allow for metabolic processes to occur within the body. So with extracellular, again, it's found outside. It's 1/3 of total body fluid. Um, there are two technically main compartments, which is the intravascular and interstitial, and then the third compartment, which contains the transcellular, which is like the lymph fluid. So with this, the principal electrolytes within the extracellular are sodium chloride and bicarbonate. Um, the the extracellular fluid is a transport system. It carries nutrients to and waste products from the cells. It contains plasma and interstitial fluid. The difference between the two is that plasma contains large amounts of albumin. The interstitial fluid transports waste via the lymph system, the lymphatic system, and the capillaries. So what happens when these fluids shift? So with decreased circulating volume, the baroreceptors in the aorta are activated. And maintaining balance of the fluid volumes, electrolyte compositions within the fluid compartments are essential to health. So if you have several loss of these specific electrolytes, such as the sodium chloride, things like that, it can, based on vomiting, diarrhea, it can cause a significant imbalance within your body. So what regulates the acid balance? Where sodium goes, water will follow. That's because they occupy the same space. So that is all combined within the extracellular fluid. So intracellular and extracellular fluids are separated by a capillary wall. This wall and the cell membrane are permeable, which is like kind of like a sponge, which allows water through kind of like the holes. It allows, the fluid shift to easily occur between the cells or the interstitial space. Fluid can be drawn back from the intracellular space from blood through osmosis. And again, just reverting back to A&P, and I'm sure your biology that you had at one point, osmosis is the movement of water through a semipermeable membrane of an area of higher to an area of lower. So a little refresher on osmosis. Again, it's movement of water across cell membranes from a higher water concentration to an area of lower. The goal with osmosis is to equalize water and the solutes. Solutes are substances that dissolves in a solvent, and solvents are a substance capable of dissolving a solute. So in the human body, the solvent is water. Okay. So think about like coffee and sugar for a solvent and solute as it would be in the body. Osmolality is the measure of total solute concentration per liter of solution. So the number of particles or solutes per unit of solution determines the osmolality. So we are going to go into that again, talking about specific kinds of fluids. So fluid classifications that we have, I know this is a refresher again. So isotonic has the same osmolality as the interior of a cell. You have hypotonic, which is a solution where solutes are less concentrated than the interior of the cell. And then you have hypertonic, where solutions where solutes are more concentrated than the interior of a cell. So how is the movement of the body fluids occur? So something called active transport, where substances move across membranes against a concentration gradient using something called ATP, which is metabolic energy. The sodium-potassium pump moves the sodium out and allows potassium in the cell to create a balance. Under normal conditions within the body, sodium concentration is higher in extracellular fluid. That's because it's one of the components of electrolyte of those. And potassium is higher in intracellular fluid. The sodium-potassium pump facilitates a transfer of sodium from the extracellular fluid to the intracellular fluid, and again, transfer from potassium from the intracellular fluid to the extracellular fluid. This creates that action potential because one's a negative, one's a positive. So this helps, again, for the responsible of cardiac and skeletal muscle contractions, nerve impulse transmission. This is what helps your organs within your body function appropriately because of that negative and positive charge. So how are we regulating? How does homeostasis occur? How do we maintain that? So kidneys are the primary regulator of fluid volume and electrolyte balance. There's a hormone called the antidiuretic hormone. This hormone regulates water excretion from the kidneys. Antidiuretic hormones are synthesized in the hypothalamus, and then they're released from the posterior pituitary gland. Once they're released from the posterior pituitary gland, it releases a response to increases in the osmolality, or remember what that is, the number of particles or solutes in the solution. So it will release that based upon what the kidneys and the output is saying. Then we have the renin-angiotensin or the aldosterone system. This assists in maintaining blood pressure and intravascular fluid status within the body. Aldosterone is then released, which promotes sodium and water reabsorption. So aldosterone is going to keep the sodium and water balance straight within your body or at a balance. And then the natriuretic peptide hormones released in wall of the atrium. This is also those are called the atrial natriuretic peptide, or the AMPs, or if it's released from the ventricle, it's called the brain natriuretic peptide, or as the lab you see as the BNP. So that is when you're looking at the BNP, especially can be seen to be elevated in patients who are in congestive heart failure because the part of the ventricles within the body is not pumping adequately. So the patient's basically in fluid overload. So the BNP is going to be elevated in those patients because of that. So that is how we kind of regulate homeostasis, is through these kind of hormones, especially with the hypothalamus and the pituitary gland will help regulate those. So again, here's this little diagram of importance of fluid volume and how it does for the brain and kidneys, how they work together, and that's what kind of keeps your kidneys to allow you to put out enough water, and not hold on to, not retain enough water. So the renal system, again, the kidneys are the primary organs in regulating fluid volume and electrolyte balance, which maintains homeostasis. The endocrine system controls the fluid and electrolyte balance, and again, it's maintained in the renin-angiotensin aldosterone system and the antidiuretic hormone. The respiratory system, fluid loss occurs from the lungs through vaporization, which occurs as a result of inspired air being warmed and humidified by the body. And then we also have insensible losses where water loss occurs through the skin, lungs, stool. It's not controllable, and especially if you are having like diarrhea, vomiting, obviously that's going to be something that's going to be a higher amount. All right, so how do we know if a patient is adequately has a balance of fluid, right? So how can we do this? How can we tell? Well, body weight is the first. In comparison to normal weight, it can provide info on either if somebody has an exceptional amount of fluid loss or if they're retaining an exceptional amount of fluid. So we can look at this through serum osmolality and urine osmolality. Typically, if you have a patient who is having some kind of disorder that's causing, either too much fluid loss or too much holding on to fluid too much, they can draw the patient's urine osmolality and their blood osmolality at the same time, and it will determine, based on the numbers, if the patient is, high or low, or if they're holding on to too much fluid or getting rid of too much fluid. So, again, so the serum and the urine osmolality should be taken at the same time. So it's going to provide more information if the patient's renal function is appropriate. If the patient does have an increase in a urine osmolality, this can be seen in patients that have fluid volume deficit, are in pre-renal failure or heart failure. So then decreases in urine osmolality are seen in patients with hyponatremia, fluid volume excess, diabetes insipidus, because of the dilution of urine and decrease in the number of particles. Patients that have increases in serum osmolality are seen in patients like with hyperglycemia, hypernatremia, and severe dehydration. And then decreases in serum osmolality are seen in patients with renal failure, diuretic use, fluid volume excess. So when there is less water, then the concentration of particles is higher. So, you're going to have, if there's fluid volume deficit, your urine osmolality is going to be higher. If you have severe dehydration, your serum osmolality is going to be higher, and vice versa. If it's decreased, it's because you are having like fluid volume excess. Then we look at the BUN. This measures the nitrogen portion of urea and serves as a measure of the glomerular function. Urea is the end product of protein breakdown in the liver. A normal BUN is typically between 8 to 21 milligrams per deciliter. This level is going to vary with fluid intake and urine output, which reflects fluid status and renal function. When there are increases in BUN, it's usually due to decreased perfusion of the kidneys. Usually if somebody has impaired renal function, and if it's secondary to like sepsis, shock, stress, congestive heart failure. If they do have those kind of states, the blood is usually shunted away from the kidneys so that the body can maintain perfusion to the heart and brain. So like the kidneys are the first one that's shunted away so that it can, take care of your vital organs like your heart and brain. If you do have a decrease in the BUN, it can be seen in a syndrome of, it's called SIADH, syndrome of inappropriate antidiuretic hormone. This can also be seen with liver failure and malnutrition. With patients with these kind of things, retention of water can occur, which dilutes the circulating blood volume, which will then decrease the BUN, resulting in the BUN being lower. Creatinine is a byproduct of muscle creatinine phosphate metabolism. Creatinine production is constant as long as muscle mass remains constant. It serves typically sometimes as a better indicator of kidney function than the BUN. Creatinine typically ranges from 0.5 to 1.2 milligrams per deciliter. And depending on the muscle mass of the individual, the normal ratio of BUN to creatinine is usually 10 to 1 or 20 to 1. And then urine-specific gravity is a measurement of dissolved chemicals within the urine. And it basically is going to tell you, it's an indicator to see if like how well the kidneys are able to like get rid of things. It will show like your hydration status, your urine volume, and the number of particles within the urine. So a normal range for a urine-specific gravity is 1.005 to 1.030. So that's how another way to indicate if somebody is having adequate fluid status. All right, so fluid volume deficit or hypovolemia is a decrease in fluid in the body and can occur in the interstitial, the intravascular, or intracellular spaces. Fluid volume deficits are a common problem, and they can coexist with acid-base disorders or if you have electrolyte imbalances. A fluid volume deficit develops when fluid losses exceed the fluid intake. So it can be because insufficient intake of fluid or fluid shifts can occur from vomiting, diarrhea. When it's hot outside, increased perspiration, especially when you don't replace your fluids with the sweat. If you're hemorrhaging, diabetes insipidus, which you're going to learn more about in level 4, diabetic ketoacidosis, which we're going to talk about later on in the semester, and then adrenal insufficiency, which again you'll learn in level 4. With administration of diuretics, that can also result in a deficit of fluid because we're giving them diuretics and they're putting off too much fluid via urine. So another thing that can happen are fluid shifts. When fluid shifts into the interstitial space, circulating blood volume decreases. This will then result in decrease in blood flow to organs of the body. Because of the decrease of blood flow to organs of the body, patients can become hypotensive, and they're going to compensate with the low blood pressure by becoming tachycardic. So their heart rate will increase because it's trying to pump more fluid or trying to pump more blood to get to the tissues that it needs to get to the organs. So it's compensating that low blood pressure. They can also be restless and have decreased urine production. Something called third spacing occurs when that fluid leaves the vascular space and then enters the space between the cells. It can be seen in patients like trauma victims, burns, especially with burns. There's a fluid shift that occurs because there are cells that kind of mediate and will try to, especially red blood cells, will go to the burned and white blood cells to try to fix it, to try to heal it. And because it's a rapid fluid shift, they can have the third spacing. Patients with cirrhosis, especially ascites in the abdomen, that fluid shift occurs because of the cirrhosis within the liver. Also, patients with right-sided heart failure can also have fluid shifts, like with third spacing. So the fluid can shift into the abdomen, ascites, especially with patients like with cirrhosis. They can have fluid shifts within the pleural space, also called a pleural effusion, or they can have fluid shifts within the soft tissues called peripheral edema. And it can be lost through disrupted skin integrity, as with burn injuries. So with those kinds of patients, especially with burn injuries, you have to give them fluids back or else they will become really hypovolemic. So that is how fluid shifts occur within the body. All right, so some signs of hypovolemia. We have weight loss, loss of skin turgor, concentrated urine output, again with that increased urine-specific gravity that we talked about, because their hydration status is they're hypovolemic, that will become elevated. Oliguria, thirst, dry mucous membranes. They can have a rapid tachycardic with a weak pulse, so it'll be really fast but very weak. Flattened neck veins. They will be hypotensive. They can have anxiety and restlessness, cool, clammy, pale skin. So what can we do for this? We can obviously have them increase their oral intake. That is the preferred thing. If they're able to drink, swallow appropriately, we want them to be able to do that. We can give IV isotonic solutions like 0.9% normal saline or lactated ringers. But remember, with 111 isotonic expand plasma volume, it will help to correct hypotension. Once hypotension has been corrected, IV solutions and the infusion rate are usually adjusted to then help correct electrolyte disturbances, because once they receive these fluids, they can then have electrolyte disturbances. So we need to then switch over to like 0.45% normal saline. So some complications that can occur, hypovolemic shock. Some signs and symptoms of hypovolemic shock are hypotension, so low blood pressure, tachycardia, again with the compensation, your body's going to try to compensate by raising the heart rate. You can have signs of organ hypoperfusion, which means, again, like it's shunting off, especially the kidneys are like one of the first things to shunt to stop the blood flow. Therefore, they're going to stop producing urine. So that's like one of your first indicators of a patient that's going into hypovolemic shock is usually they're going to have less than 30 mLs of urine output an hour. They can also have cool, clammy skin. Again, the oliguria progressing to anuria, which is absolutely no urine, not ability to make any urine. Then they're going to have decreased level of consciousness and they're going to start to have tachypnea based on that. All right, so crystalloid. They are, again, solutions that contain small molecules that flow easily across the cell membranes, allowing for transfer from the bloodstream into cells and body tissues. It will increase fluid volume in both the interstitial and intravascular spaces. So we have the crystalloid. It includes hypotonic, isotonic, and hypertonic. So hypotonic are 0.25% normal saline and 0.45% normal saline, also D5W. This, again, will shift fluid out of vessels into cells. It will help to hydrate those cells. It can worsen hypotension. So if somebody is having a low blood pressure, we do not want to give them a bolus of half normal saline because this is not going to help that. It will worsen it. It can increase the edema. So if they're third spacing already, can increase that edema. It can also cause them to have low sodium. So just be considerate, mindful of those. With isotonic, which is 0.9% normal saline and lactated ringers, there's no fluid shift. It's vascular expansion, so it's going to expand the vascular fluid. It will help with electrolyte replacements. It can cause fluid overload because, again, it's going to be in that vascular volume expander. It can cause generalized edema. It will dilute the hemoglobin because we're kind of hydrating the blood essentially, so it's going to decrease the hemoglobin. Can cause electrolyte imbalances, things like that. Hypertonic, which is D5 half normal saline, D5 normal saline, or 3 to 5% saline. This will allow shifts the fluid back into the circulation. It's a vascular expander. It will replace electrolytes. It can be irritating to veins. It can cause fluid overload, can cause hypernatremia because it's a high level of sodium that we're giving them. So those are things with the crystalloids. Colloids. Colloids are solutions that contain very large molecules that do not allow the pass through that cell membrane. They remain in the intravascular compartment and expand the intravascular volume. So things like this are albumin, 5 or 25% albumin. It keeps fluid within the vessels and maintains volume. This is treated typically in patients with shock as it is a volume expander. Can cause anaphylaxis, so we need to watch for hives, fever, headache. It can also cause fluid overload and pulmonary edema. So when you are administering albumin, we need to keep in mind of listening to the patient's lungs because it can cause pulmonary edema. So we need to make sure there's no crackles in the lungs, that they're not having extensive like JVD, things like that. Then we have dextran. This will help to shift the fluids into the vessels as well. It is also a vascular expander. Again, this one also can cause fluid overload and hypersensitivity, can increase a risk of bleeding. So we don't want to give it to patients who have bleeding disorders, have congestive heart failure and renal failure, because it will put too much pressure on the heart and the kidneys. We have something called HES, or synthetic starch. Again, it's a shifts the fluid into the vessels, also a volume expander. Can cause fluid overload, increased bleeding. Same thing with contraindications. And then we have mannitol. Mannitol is used a lot of times in patients in the ICU that have like neurological disorders. So it will help to treat when you have diuresing, when there's low urine output. It will help